Hello, this is Mark Rothstein, and I'm with you again today for one of my COVID talks. This is the fifth video in a series that began shortly after the pandemic, and the last one before today was on July 20th, 2022. In today's video, I will address three main questions. First, is COVID over? Second, what is the value of the new bivalent Omicron boosters? And third, I'll try to answer some of the important questions that have been submitted to me within the last few days. Once again, I want to start my talk with the usual disclaimers. I am not a physician, and nothing I say should be considered medical advice. I am also not an epidemiologist, virologist, or other type of scientist. My background is in public health ethics, law, and policy. I have served as an advisor to the CDC on coronavirus policy. I am former associate editor for public health ethics and law of the American Journal of Public Health, and I have written widely on the public health response to COVID. This video is being recorded on October 16th, 2022, and we can assume that the facts surrounding the pandemic will change over time. So when you listen to this, keep in mind the date that it's being recorded. Let me begin with the first question, and that is COVID over? Obviously, all of us want COVID to be over. It has been a long, difficult, and very trying time on a personal and population basis. Our political leaders want COVID to be over for various reasons, including that their constituents want it to be over. And for some low-risk people, the likelihood of getting seriously ill is now very low, but that is certainly not the case for everyone. The U.S. has 4% of the world's population and 17% of the COVID deaths. To me, this is an astonishing figure, because unlike low and middle income countries, we have access to vaccines, boosters, treatments, and excellent medical care. Yet for reasons that often escape me, many people do not believe COVID is real or that bad. They deny they're at risk. They put great weight on medical nonsense and are seemingly indifferent to the health risks of others. And these attitudes are deadly. There was a recent study from the Texas Department of Health that said that unvaccinated people have a 16 times greater risk of dying from COVID than those who have been vaccinated. Of the more than 1 million deaths in the United States from COVID, hundreds of thousands of people, their deaths were preventable. An anti-public health mindset places all of us at risk. One consequence of letting an unstable pathogenic virus replicate in a large population is that it increases the likelihood of new mutations, such as the deadly Delta variant in 2021 and the highly contagious Omicron variant and subvariants in 2022, with even newer subvariants emerging, and I'll talk about those in a minute. A common argument that I hear is that COVID is no worse than seasonal influenza. In fact, COVID is much worse than the flu. According to the CDC, each year there are 30,000 to 40,000 deaths from flu, with older people most at risk of dying. There are currently about 350 deaths per day from COVID, and this is expected to increase during the winter months when people spend a greater portion of their time indoors. The result will be 120,000 to 150,000 deaths in the next 12 months. The bottom line is simple. COVID causes 4 to 5 times as many deaths as the flu. In addition, there's the issue of long COVID, which is defined as when a person at least 3 months after recovering acute symptoms has one or more of the following symptoms: fatigue with aches or mood swings, cognitive problems, sometimes referred to as burnout, or respiratory problems. Of the percentage of people who go on to develop long COVID in the US vary quite widely, but I think up to about 1/3 of the cases might be affected. More research on long COVID will certainly give us a better idea of the actual numbers. In any event, we still don't know the biology of long COVID, how long symptoms will last, or how best to treat it. We do know that vaccination, including boosters, helps prevent it. COVID illnesses and deaths are not the only effects. There is also the isolation and depression of elderly and medically vulnerable individuals, the stress and disruption of the lives of family members, the toll on our healthcare providers and health system, the impaired educational and social development of our children, and the numerous ways COVID has seemingly drained the joy from them. It may well be that COVID is now endemic in the population and will always be with us to some degree or another. But it is disheartening to observe the lack of social solidarity, the widespread opposition to even minimal public health measures, and the disregard for the well-being of others that also seems to be endemic in the United States. So after that cheery beginning, I'd like to now proceed to talk about the new bivalent boosters for the Omicron subvariant. The original strain of the coronavirus SARS-CoV-2 is known as the Wuhan strain, named for the city in China where it emerged. Although we have gone through a series of Greek letter variants, starting appropriately with Alpha, the various vaccines, including those from Pfizer and Moderna, are intended to develop a degree of immunity to the Wuhan strain and thereby prevent serious COVID cases. Fortunately, the emerging variants so far have been quite similar to the Wuhan strain, so that the original vaccines remain effective in preventing life-threatening cases of COVID. But vaccine protection against infection declines over time. After 20 to 30 weeks, protection from the Pfizer and Moderna vaccines declines from over 90% to between 50 and 80%. That's why the original booster shots were developed. Some of the loss of protection is caused by declining levels of antibodies, but it also can result from the emergence of different or more evasive strains of the virus. Decreased antibody levels is associated with an increased likelihood of contracting COVID and possibly transmitting it. But T-cell protection from vaccination lasts longer and helps to prevent the most severe cases. The new boosters that we hear so much about are called bivalent because they are designed to protect against both the Wuhan strain and the subvariants BA4 and BA5. The Pfizer bivalent is the same dose as the original vaccine, in other words, 30 micrograms, but it is 15 micrograms to counteract the Wuhan strain and 15 micrograms to counteract the Omicron subvariant. The Moderna dose is also the same as the original, but in 50 micrograms, and therefore 25 micrograms are for the Wuhan and 25 micrograms for the Omicron. Until quite recently, I mean within the last week, about 95% of the cases in the US were reported to be of the Omicron BA5 subvariant. But according to data from the CDC released on October 14th, 2022, the BA5 variant had declined to 68%, and new variants have emerged. The BQ1 and BQ1.1, which are both closely related to the BA5, now account for 11.4% of the cases. And another variant, the BA2 72.2, was the cause of 1.4% of cases. I think these numbers show how quickly things can change with this pandemic. A booster 100% geared to a specific variant, such as Omicron BA.5, would probably be more effective than a bivalent booster. But because of the likelihood of new mutations arising at any time, the Wuhan component gives added protection against emerging strains. The bivalent boosters were developed to home in on the dominant strain, but also serve as a hedge against future variants. And I think it will probably prove to be a good strategy. Most experts believe that all new boosters going forward will be developed to protect against multiple strains. So the boosters will be bivalent or trivalent continuing in the future. Fortunately, the mRNA vaccine, Pfizer and Moderna, can be reformulated in a short time to protect against specific variants and subvariants. So far, there has been little interest in the bivalent booster, and this is very disappointing to me. As of October 16th, that is today, only 15 million people have received the bivalent booster, which constitutes less than 10% of those who are eligible. I think one reason is that many people think COVID is over and they have booster fatigue, as it's sometimes called. Another reason might be because the bivalent boosters have not been tested in humans. Now, this is seemingly scary, but it's not unusual for vaccines. Each year, the flu shot is formulated many months in advance of flu season because of, based on experts' assessment of what the likely flu strains will be circulating in the coming flu season. Sometimes it's an accurate projection and the vaccine is highly effective. In other years, the vaccine's effectiveness may be as low as 50%, which is not great, but it's still better than nothing. A bivalent booster to combat the alpha variant was tested in humans when it was the dominant strain. The Wuhan alpha bivalent booster was shown to be safe and effective. And virologists believe this will be true for the Wuhan Omicron BA.4, BA.5 subvariant booster. But we won't have good data on how much additional protection it gives until we have so-called real-world data from humans, which will probably take a few months to get. I should note, for the record, that I got my bivalent booster as soon as it became available. Now, who should get the bivalent booster? At least people from these three categories. First, older people whose more rapidly declining immunity will get a significant boost from the shot. Second, people with comorbidities, especially those who are immunocompromised. And third, close family members and other contacts of people with serious health problems, so they won't spread them. The only people who should avoid this booster are those who've had serious adverse reactions to the original vaccine and boosters. And here I'm talking about anaphylaxis and not soreness at the injection site or some other minor adverse reaction. The third part of my talk, I want to answer some of the questions I received, and time does not permit me to answer all of them, but I think I've got a pretty good sample to review. So first, I want to answer this question. When will it be safe for immunocompromised people to be in the world again? This is an extremely important question, and there is no simple answer. In my view, it depends on three things. First, what is the nature and extent of the person's medical condition and the likely consequences if the person becomes infected? This is a medical question that the individual needs to discuss with his or her medical team. Second, what does it mean to, quote, be in the world again, unquote? In other words, what is the likely exposure? And here the answer depends on where the person is going and for how long. including the transportation to get there. Will it be outdoors or indoors? How many people will be there and how close together will they be? Will there be food and drink served? Singing or loud cheering, which increases the risk of respiratory spread? Will the other people be vaccinated or wear masks? So there are lots of these questions that one needs to ask to decide whether it's worth the risk. And then third, the final part of my analysis is, what is the person's risk tolerance? Even low risk exposures might make some people so uncomfortable that they wouldn't have a good time anyway and might be better off not going at all. Now, nothing would make me happier than to say to everyone who has had to lead a sheltered life for over 2.5 years, it's over and it's safe to rejoin the world any way you want. But I don't think we can say that yet. Each person will have to weigh the risks and benefits for themselves. I suggest that if you feel ready to increase your role in public, you should do it incrementally. Next question, what is the AstraZeneca vaccine? Unlike the Pfizer and Moderna vaccines that we're mostly familiar with in the US, which are mRNA vaccines, AstraZeneca is a traditional viral vector vaccine like the J&J vaccine. It is a 2-dose vaccine currently approved for people 18 and older. It's safe and effective and also lower cost because it doesn't require extra cold refrigeration. AstraZeneca has been working on a nasal spray version of the vaccine, but the results of clinical trials reported this week were not positive at all. So don't look for a COVID vaccine in a nasal spray form anytime soon. Third question, should I choose Pfizer or Moderna for the bivalent booster? I think either one is fine, and it doesn't matter which vaccine or booster you had in the past. You can mix and match with no problem. Number 4, I'm out of the country and unable to get the bivalent booster. Should I get a regular booster? Yes. Over time, the protection of your earlier vaccine wanes significantly. Don't wait for a bivalent booster. Number 5, I recently had a mild case of COVID despite 4 doses of the vaccine. How paranoid should I be? Answer, not at all. The vaccine and boosters were designed to protect you from a severe case of COVID that would require hospitalization or worse. The vaccines worked. Having a mild case of COVID also will confer an additional layer of immunity going forward. And the final question I want to answer is the vaccine requirement going away in workplaces? Many employers have discontinued mandatory vaccination requirements, but they still can require vaccination for workplaces where unvaccinated workers constitute a direct threat to other workers. I believe this includes the entertainment industry. Except for some voiceover actors, musicians, and some others, performers cannot work from home, wear masks, or otherwise engage in social distancing measures. Unvaccinated performers pose a direct threat to others, including immunocompromised cast members. The religious objection to vaccination based on the use of fetal cell lines in developing the mRNA vaccines is no longer valid because there are other approved vaccines that did not use fetal cell lines in their development. So now I have a few concluding remarks. Going over my talk before presenting it today, I recognize that some of my comments have been, shall we say, negative. So I'm going to ask myself this final question. And the final question is, are things getting better? Unquestionably, yes. For example, some of you might remember prior videos where I talked about staggering numbers of COVID hospitalizations causing emergency departments to turn away patients with heart attacks, strokes, or serious trauma. That is no longer a problem. We have new tools to detect, monitor, prevent, treat, and limit the severity of COVID, including the bivalent boosters that I'm working from today. Our challenge is to make sure these measures are equitably available in the US and globally, encourage their use, and counter the misinformation and divisiveness that make people unwilling to accept measures to save their own lives, and in so doing, threaten ours. COVID is not over for many people at increased risk. But things are getting better. So please be safe and careful, but don't let COVID rule your life. Thanks for watching this to the end.